It was around 2021 that GLP-1s really started to become household names for diabetes and weight loss. And in the field of addiction medicine, those of us practicing in clinical settings started noticing that we had patients reporting these kind of unsolicited reductions in their addictive behaviors. So patients describing them basically as um, a loss of their usual desire for alcohol or nicotine or whatever drug they had they use, and also for problematic behaviors like compulsive shopping or gambling. So with our existing knowledge of how GLP-1s work in the body, combined with these anecdotal reports from our patients, it really started to kind of catalyze more investigation into this area. And what we're seeing on the horizon is potentially a pretty big shift in how we think about and how we treat addiction. And there's a couple reasons that I say big shift. So, first, um, GLP-1s, they may allow us to move from a substance specific treatment to treatments that address different types of addictions or even polysubstance use. So traditionally, our medications in addiction medicine, they're very targeted. So we use often methadone for opioid use disorder. We'll use Chantix for nicotine dependence or Antabuse for alcohol use disorder. But GLP-1s act really as broad neuromodulators. They act on the brain's reward sensitivity. And because of that, they show potential across a wide range of substances. So that's one exciting aspect. And then the second big reason for a potential shift is that GLP-1s may fill gaps in our current treatment toolbox. So right now, we don't have any FDA-approved medications for certain addictions like cocaine and methamphetamine and cannabis use disorder. So GLP-1s may provide pharmacological options that can supplement the therapy and counseling that we currently use for some addictions and hopefully lead to better outcomes. So in healthcare, of course, we mainly know about this class of medications for diabetes and obesity. And among the general public, they've definitely acquired this reputation of being weight loss drugs. And their major mechanism is mimicking a natural incretin hormone that stimulates insulin secretion. It suppresses glucagon. It slows gastric emptying, and that increases feelings of fullness and satiety. But we know that GLP-1 receptors, they aren't just in the pancreas or just in the stomach. They're expressed in the brain, specifically in the mesocorticolimbic system, which is the brain's reward center. And that includes specifically the ventral tegmental area and the nucleus accumbens. And that is the main pathway involved in addictions. So when a person with a substance use disorder uses a GLP-1, they're or let me back up. When they use a drug, they're getting a supra physiological blast of dopamine, basically, that projects through that reward pathway. And that surge is really what kind of staples that drug use behavior into the brain and creates that compulsive drive to keep using a substance or keep it engaging in a behavior. But when we use a GLP-1 receptor agonist, it essentially can dampen that dopamine spike that can come from addictive substances. So a patient can go from constantly craving a substance to feeling like they don't need it or not thinking about a drug as much. And that's one of the reasons that patients taking these medications for weight loss don't want to eat as much, or they talk about not having that food noise in their brain that was previously so bothersome to them. So with addictions, we can get some of that same effect, but with drug use instead of food. And GLP-1s can essentially dampen the excitability of these neurons and muffle those spikes. And really, what's even more exciting is that they seem to do this without damaging the brain's baseline dopamine tone, meaning that they can diminish that drive for drug use while still allowing a patient to get enjoyment from the usual things in life that should lead to enjoyment and should lead to a natural, more modest dopamine release. I think that alcohol use disorder is probably a good place to start here because it's the area that we've seen the most robust data to date. And we've seen it validated basically in two ways. So, first, clinical trials. We recently had a phase 2 study published where semaglutide led to medium to large reductions in alcohol consumption, as well as a decrease in heavy drinking days and alcohol cravings. And there's also been a very large Swedish registry study of over 200,000 people. And that study found that the patients who were on semaglutide, they had significantly lower risk of ending up in the hospital for alcohol related issues. So a lot of promising data with regard to alcohol addiction. And then I would say next after alcohol, we probably have the most evidence for tobacco and nicotine. And this one is a bit more of like a mixed bag right now. But we've seen pilot trials where adding a GLP-1 to a nicotine patch really boosted abstinence and reduced nicotine cravings. Though there are a couple of other trials that really didn't show the same long-term efficacy. But importantly, for pharmacists who deal with patient counseling a lot, one consistent benefit that we see is that GLP-1s can really help eliminate weight gain that often comes with smoking cessation. So that's sort of a different way that they can be helpful when it comes to nicotine. Some patients, as many listeners probably know, they're almost scared of quitting smoking because they don't want to gain weight when they stop. So whether it's the GLP-1 or the nicotine replacement or just their own discipline and motivation that is the primary driver of them quitting smoking, the GLP-1 can potentially remove a barrier to them actually picking a quit date and then maintaining smoking abstinence. With regard to opioid use disorder, I think we're a little earlier on in the evidence that we have here, but animal data here is pretty strong. There is a pilot study with uh, liraglutide where cravings dropped pretty significantly. And looking at retrospective data, the evidence shows that there's a lower rate of overdoses in patients who are on GLP-1s. And of course, when it comes to opioids, if we can find anything that reduces the overdose risk, we're paying very close attention to that. And then in terms of stimulants like cocaine or methamphetamine, it the studies have been, I would say, almost disappointing so far. In that one study of cocaine use didn't show any change in the experience of a cocaine high or cravings with a GLP, but it really looked at the immediate effects after a single dose. And as we know, addiction is a chronic disease, so we really need to be looking at chronic dosing of a medication to probably see positive results. And then cannabis as well, we really only have observational data, but do notice that people in our observational studies seem to be less likely to be diagnosed with cannabis use disorder. And that brings up kind of another whole area in which this class of medications may be helpful in addictions, and that is prevention of substance use disorders in addition to just treating them. And there was actually a study just published in BMJ this month that was an observational study of Department of Veterans Affairs data, and they found that GLP-1 use was associated with reduced risks of adverse outcomes in people with existing substance use disorders, but also that GLP-1s were consistently associated with the reduced risk of developing various types of addictions. So I think that preventive effect is very exciting as well. Since we don't have that FDA approved indication for addictions yet, we are in kind of this gray area where we're often prescribing them for a metabolic issue, either obesity or diabetes, but we're keeping, at least in the field of addiction medicine, we're keeping a very close eye on control of any comorbid addictions. So a physician might prescribe a GLP-1 for a metabolic issue while making it kind of a conscious part of the patient's addiction treatment plan, hoping that it simultaneously helps them to stop their drug or alcohol use. And that's not really a new concept in medicine. Using this sort of dual benefit prescribing, for example, thinking about clonidine, I might prescribe it for a patient's opioid withdrawal symptoms, but then also notice that it helps their hypertension, and then it becomes intentional that I'm treating both. Or propranolol, I might prescribe it for someone's heart rate control, but intentionally pick that specific medication because I know it might help with their anxiety at the same time. So we're doing the same thing with GLPs right now. And thinking about what the pharmacist's role may be in this, I do think that pharmacists can play a major role in monitoring and patient safety. We know that the most common side effects are gastrointestinal related. They're nausea, vomiting, diarrhea. And when we're thinking about patients who are in early recovery for opioid use or alcohol use, those are the same symptoms that they're going to have during a period of withdrawal. So that can get confusing. So if a patient says they're nauseous, pharmacists can be thinking about, is this the GLP, or is this patient slipping into withdrawal, and help distinguish those. And then on the mental health side, data has not shown any clear link between GLPs and suicidal ideation, but the patient population of those with addictions is really a vulnerable group. And addiction and depression really, they co-occur so frequently that I would say, as a pharmacist, if you're at the counter and you see a change in a patient's mood, or they have a very flat affect that you hadn't noticed before, advise them to talk to their doctor, because we really want to monitor those depressive symptoms very closely. And kind of along those same lines, I would advocate for slow titration of GLPs. Eh, we shouldn't be rushing the dose, especially in someone who's dealing with physical instability of early recovery from an addiction. So starting low in the dose and titrating slowly, and educating the patient about why we're doing that. That can also just help them to quiet those drug cravings while also minimizing those gastrointestinal effects. So a pharmacist might suggest that a patient stay at their current dose for an extra couple weeks, or even back down one level. With addictions, we really need to keep them on treatment long enough that they can establish new lifestyle behaviors and routines that they can stick with in the long run. So I talked a little bit about the kind of exciting anecdotes we have from the field of addiction medicine in terms of how GLP-1s seem to be making a difference for our patients, and some of the smaller studies that show positive results. But we really need to move from all of that toward gathering the required evidence that will actually help get official FDA indications for addictions. And I don't want to downplay how much has already been done in the research, but to get those FDA indications, we really need those large scale phase 3 trials. And in addition to results from those studies in general, as we move forward, we also need to have a better understanding of dosing, because I don't necessarily think that it will be the same for the indications that GLP-1s are already approved for. In addiction medicine, I kind of suspect that we might find less is more. I wonder if lower doses than what we use for obesity might be enough to help manage someone's addiction without causing side effects that make them want to quit. Um, we also we don't know yet if patients will develop potentially a tolerance to the anti-craving effect that GLP-1s appear to have, or if they might experience a rebound in their substance use if they stop the GLP, similar to the rebound weight gain that we see for people taking it for obesity. Um, so I think that's what we need in terms of scientific evidence. Even if the science is there, I do think we'll have a big hurdle in terms of insurance coverage. So right now, without an FDA indication, getting these covered specifically for addictions is nearly impossible. Um, and as your listeners know, insurance companies, they want to see hard outcomes and actual FDA approval before they're going to cover an indication. But we've seen this struggle before in addiction medicine. Buprenorphine, for example, when it was first approved for opioid use disorder, it was initially covered by some payers only in patients who had failed other treatment approaches. And we've graduated away from that. So it might take even longer after we have the science to really see system-wide support. Um, and with the price point so high for these medications, there may be some pushback from insurance companies. But I think for pharmacists, you're often the experts in these access barriers, and will likely be the ones to help us identify patients who have the best chance of coverage with their insurance. So, I foresee prescribers and pharmacists really being partners here and um, helping to manage polypharmacy as we combine GLP-1s with standard treatments, helping to monitor patients, as I mentioned before, for adverse side effects or those rebound signs if they have to stop the medications due to cost or supply issues. And I'm really optimistic that this class of medications can become a standard and accessible part of how we treat addictions of various types.